that correctly is just amazing. So this is our protocol review that for this amendment. We've all had quite a bit of training. If you are new to us, I don't know that there is anybody new, but we still have the full original training before the amendments. And if you need additional information, always just please reach out. So this slide of our core staff is just here for reference. These slides will be on box so that you have this if you need it. So with our study design, again, it is double-blinded and randomized for severe alcoholic hepatitis. We're doing this study to determine the efficacy and safety of anakinra plus zinc compared to the current standard medical treatment, which is prednisone. And the secondary objectives will be evaluate the use of the biomarkers to assess disease severity and treatment response, and hopefully to develop some novel endpoints to overcome the illness, the limitations of the current assessment strategies. So it is a phase 2B comparing anakinra and prednisone. All participants will receive the standard care for treatment as described in the recent guidelines. We're conducting it at 8 clinical sites, and these have been selected by the NIAAA and will be supported by the Data Coordinating Center here at IU. And the biorepository, as you know, will be managed by the University of Massachusetts. The primary endpoints are the survival at 90 days with secondary endpoints of changes in scores, any organ dysfunction, infections and sepsis, and renal dysfunction, need for care escalation, the indicators of the gut permeability, which are study level tests, and the survival at 30 and 180 days. So things that have changed, our enrollment total now, our goal is 258 subjects. So still 129 in each of the remaining 2 arms. We're hoping that each site can enroll 32 to 33 participants total over the time period of 5 years. We're hoping that when we start, we'll be able to get 6 to 7 participants per site this year. So we still have that manual of clinical operations and best practice guidance, which was outlined in the protocol. So this is a manual that our investigators came up with, Dr. Garay primarily, and it will be modified if needed throughout the course of the trial, but it's really to help guide those treating patients with alcoholic hepatitis. And we know that approach is different across all sites, but this is part of the collaboration to help increase general awareness and guidance for this disease. So we do hope that you will share it with all of your co-investigators, coordinators, and with the ICU and hospitalist services at each of your sites. The important references that will be in box are listed below that also helped develop this manual. So study arms and medication, these are the important changes. We now have 2 arms that patients will be randomized to after meeting all of the inclusion and none of the exclusion, and of course signing informed consent. So the group 1 is the standard of care plus prednisone, 40 milligrams orally once a day for days 1 through 30, and then matching placebos for the anakinra, which is 1 syringe once daily, subcutaneously, and zinc matched pill once daily on days 1 through 90. Group 2 is the standard of care plus the anakinra, which is 100 milligrams subcutaneously once daily on days 1 through 14, and zinc sulfate 220 milligrams once daily on days 1 through 90, and a placebo for the prednisone, which will be a matched pill once daily on days 1 through 30. There will now be 2 separate bottles of oral medication that will be dispensed, and the WAL score will be calculated from day 7 labs. Participants will stop prednisone or prednisone placebo if the score is greater than 0.45. Inclusion and exclusion. Nothing has changed in inclusion. The primary first will be the alcoholic hepatitis, which is defined by the NIAAA. The onset of jaundice, which is defined as serum total bilirubin greater than 3 milligrams a deciliter within the prior 8 weeks to the screening visit. The regular consumption of alcohol with an intake of greater than 40 grams daily or greater than 280 grams weekly on average for women, and greater than 60 grams daily or greater than 420 grams weekly on the average for men. For 6 months or more with less than 8 weeks of abstinence before the onset of jaundice. The AST should be greater than 50 IU per liter. The AST to ALT ratio should be greater than 1.5, and both values should be less than 400 international units a liter. And or histological evidence of alcoholic hepatitis. The MELD should be 20 to 35 on the day of randomization. In patients with possible alcoholic hepatitis or AlcHep with confounding factors, including those listed, a standard of care liver biopsy may be performed during current hospital admission to confirm the alcoholic hepatitis and exclude competing etiologies. This would be something that was ordered by the regular care team, but if it is under question, would be needed to qualify. So exclusion criteria, we do just have one change for the COVID testing, but to run down, if the score is less, the MELD score is less than 20 or greater than 35, if they have any active sepsis with SIRS or hemodynamic compromise requiring intravenous pressors. The pneumonia as evidenced by any radiological exam, multi-organ failure, renal failure defined by a GFR of less than 50 milliliters a minute, clinically active C. diff infection, any history of imaging of the liver, showing other causes of jaundice, history of other liver diseases, including Hep B, Hep C, Wilson, genetic hemochromatosis, alpha-1 antitrypsin deficiency, or the strong suspicion of drug-induced liver injury, any history of HIV infection, with meaning a positive HIV RNA or they are on treatment, any history or presence of cancer other than non-melanoma skin cancer, history of other significant medical problems such as autoimmune diseases, severe asthma, etc., that might require immunosuppressive treatments, any prior exposure to experimental therapies in the last 3 months, prior exposure to systemic corticosteroids or immunosuppressive therapy for more than 4 days within the previous 30 days, any need for inotropic pressor support to maintain perfusion to critical organs within the prior 48 hours before randomization, any clinically significant pancreatitis, a total white blood cell count of greater than 30,000, known allergy or intolerance to the therapeutic agents, inability to voluntarily obtain informed consent from participant or guardian, perceived inability to follow study procedures and comply with protocol, a platelet count of less than 50,000, and our addition of the positive PCR test for COVID-19 within 7 days prior to the baseline visit. So this is exclusionary only during the screening period. If for some reason your patient tests positive, anytime after the randomization, a positive PCR test for COVID-19 will be considered as an SAE. So the screening period is less than or equal to 7 days prior to randomization. Patients with a clinical suspicion of sepsis will have an initial run-in period of 48 hours while being screened. And then regarding the clinical suspicion, you know, just wait to make sure all of your results have come in for your blood cultures, etc. These are commonly done in these patients. So the capsule cannot be opened. Melissa Allard pointed this out to us. So please take note if your patient has the inability to swallow, or you know, they have some sort of NG tube that their medication is being put down, they will not be eligible. So something that Melissa Allard pointed out, which I'm grateful for. Our study visits procedures, so not too many changes. Of course, signing consent, verifying the inclusion and exclusion, assessing your MELD scores, medical history, vital signs, etc. The ConMeds within the past 30 days, a baseline ECG within the screening period, any liver biopsy samples during the current admission, basic chemistry, hematology, hep function, and coag tests, serum pregnancy for screening if eligible for that, and then the PCR test for COVID-19 if it's not been done as standard of care. I know most places, I think, are doing those now for all hospital admissions. So the questionnaire, the timeline follow back is backward 30 days from last drink, and remind them that if possible, they should fast for 8 hours prior to the next visit. Does anybody have any questions about the COVID testing? Okay. So just our study identifiers. These are listed in the MOP per institution. If they are a screen failure, so they sign consent but they don't meet the criteria, complete the registration form, the eligibility form, and enter them into REDCap. If you had study samples that were collected, please keep those. Do not discard those and send them with your regular shipment. So day 0, again, not a lot of changes. Important to note that you will be assessing the MELD score and entering it into the REDCap database for that day. You cannot randomize without this MELD score. So you need to enter it prior to randomizing. And the pharmacist will randomize based on your MELD score entry and verification that they meet all inclusion and exclusion. You will need the standard of care labs as listed if it's greater than 1 day has passed since screening, obtaining your biospecimens, dispensing the study medication, and reminding them that they must not chew, open, crush the capsule, instructing them on the subcutaneous injection procedures and providing the handout, and again, asking them to fast if possible prior to the next visit. So day 3, again, there is the only dispensing day is day 0, unless we have an as-needed dispense, which we will talk about in the next slide. So no changes to our day 3 procedures. Again, reminding them fasting if possible before the next visit. So day 7, this is when you are going to calculate the Lyle score. If it is greater than 0.45, the participant should stop taking the prednisone or the prednisone placebo. Obtaining your standard of care labs and biospecimens. Again, we list out the anakinra test, but they are part of the study labs. So we have had some questions of whether that's a special lab for local labs. No, it is part of study labs. Remind them that they're to be fasting if they can prior to the next visit. Assessing their medication compliance, which for syringes, if they're inpatient, will be scanned, but if for some reason they're outpatient, we will just go off the medication log that we have given them to record. You will dispense study medication if you need to based on the safety lab results. So if they have any of our safety lab results that need to be substituted for placebo for the anakinra, you will be able to dispense on day 7. Day 14, nothing has changed here, so just your standard, collecting alcohol consumption, medical history, and a urine pregnancy test, questionnaires, vital signs, any changes to CONMEDs or AEs, assessing the MELD score, standard of care labs, study labs, the medication compliance, which is always important, and remind them to fast if possible. I apologize. Someone has knocked at my door. I'm going to mute for a second. Okay, so I think maybe we've got that under control. Days 28, 60, and 90, plus or minus 7 days is the range for that. So medical history, alcohol consumption specifics, physical exams, vital signs, questionnaires, AEs, changes to medication, MELD and LAL scores, your standard of care labs, biospecimens, including the saliva. So this is our second saliva collection on day 90. Reminding them to fast when possible. And again, medication compliance. Day 180, which is our only follow-up visit, is plus or minus 7 days, and medical history, and nothing has changed here. So biospecimens, labs, changes to CONMEDs, any AEs. For missed visits, we have a phone call script, early termination procedures. So if they withdraw consent or they discontinue treatment prematurely, we would like them to complete the assessments on day 60 if the patient is willing. If they discontinue prematurely during the follow-up phase, we would also like them to complete the assessments from day 180 again if they're willing. Unscheduled safety visits, so anytime that you need them to bring them in, the designated study physician, Dr. Galway, should be contacted that you're bringing someone in for a safety visit so they're aware of the pending safety issues. Drug administration. So day 0 is when we are randomizing, entering into the REDCap system. If there is a system failure, the randomization will occur outside of REDCap. There is a backup emergency plan in the manual of operations for pharmacy. The IUDCC will maintain the current offline randomization list, and they'll be able to act as the emergency support team until the current system is restored. The coordinator, of course, will ensure all medication and dosing instructions are understood and provide them with the injection instructions, sharps container if they need if they are outpatient, and our medication log, and they will begin actually taking the medication on day 1. So to avoid the potential interference with the concomitant medications, we will administer the blinded tablet at least 3 hours apart from other medications the participant will take, and double check with your site IDS to ensure the scheduling compliance of medications, providing them the compliance log and instructing them, how to complete it and that it is for their safety. So to please be honest in recording. That instruct them that they should retain all study medication even if empty, and then returning them to the investigator at the visit. Per section 2.13 of the protocol, the drug interactions. So there is a list of the ConMeds that Melissa Allard has provided, and this will be in red cap that we just need to attest that they are not on any of the medications of issue and that all safety has been covered for the patient. So they'll receive on day 0, the patient will receive 2 bottles of oral therapy now, 1 of the 30-day supply of prednisone or prednisone placebo, and a 90-day supply of the zinc and zinc placebo. And they will receive 1 bag of subcutaneous therapy for the anakinra or anakinra placebo. Day 7, if they need new medication based on the safety labs, they will be given new blinded medication from the pharmacy. If they miss a dose, instruct them to take it later this same day as soon as they remember. They should not take missed doses on a subsequent day. If they do miss a dose, please ask them to record it on the medication log and continue to monitor whether or not they should be eligible to continue the trial if they're not compliant. Unblinding, so non-emergency unblinded is in detail in the protocol. We'll be covering emergent unblinding. If a medical emergency necessitates unblinding, the site investigator will contact Dr. Guyray to discuss the rationale for unblinding. If there is a difference of opinion as to the unblinding, Dr. Guyray will defer to the site investigator, who retains the final right to seek unblinding. And then the site investigator will communicate with the DCCIU about the decision to unblind, and the DCCIU will unblind the participant by interacting directly with the site investigator. So the rules for unblinding quickly, for leukocytosis and for concern for sepsis, if their leukocytosis is greater than 30,000, the clinical care team may actually request the unblinding. If the participant develops hypotension or requires transfer to an ICU, again, the clinical care team may request the unblinding if they believe that the treatment would impact care decisions. And then if the participant develops any other serious adverse event that is in the opinion of the investigator probably related to one of the study drugs, the clinical care team may request unblinding if they believe it would impact care decisions. Only the designated sub-investigator at each site will be unblinded. The clinical care team and the DCC contact. The designated sub-investigator who can be contacted if the participant care team has concerns about rising leukocytosis. So make sure that all patient care teams have that contact number. The sub-investigator will communicate with the IU-DCC to unblind the participant and then inform the care team of the study drugs the participant is receiving. The IU-DCC will build this into the database system and keep track of unblinded participants. And the decision to begin antibiotics for possible infection is left to the judgment of the clinical care team. Drug holding and stopping. If one of the following is met, the drug should be held for 3 days. documented infection, so pneumonia, positive cultures in blood or ascites for bacteria or fungus, positive fungal cultures only in urine, central nervous system infection defined as a positive culture of white blood cell greater than 5 in the cerebral spinal fluid, severe soft tissue or bone infections, including a clinical diagnosis of cellulitis. And SIRS is the second criteria, defined as 2 or more abnormalities in temperature, increased heart rate, respiration, or white blood cell count with increase in SOFA score greater than or equal to 2. And they'll be reassessed on the 3rd day to determine if studied drugs could be resumed or should be stopped. They'll be reassessed on the 3rd day of the study drug hold. If the infection clears and participant stabilizes, study drugs will be resumed. For participants with documented infection, if it's responsive to antibiotics and they are stabilized or improved, the study drugs may be resumed at the discretion of the clinical care team. If there is no improvement after 3 days, the study drugs will be stopped. If they meet only the SIRS plus SOFA criteria for stopping, if the cultures of urine, blood, ascites, stool are negative and the chest x-ray is unchanged, study drugs may be resumed again at the discretion of the clinical care team. If they have a second hold of study drugs due to infection or SIRS plus SOFA criteria, study drugs will be stopped. And the participants in either arm who do not drop the Lille score to less than 0.45 on day 7 will stop bottle 1 of the prednisone placebo and will continue with bottle 2 of the zinc or zinc placebo. Drug stopping rules, so if they have no improvement or stabilization after holding study drugs for 3 days, a second hold of the study drugs due to the infection or SIRS SOFA criteria, or development of severe leukocytosis, which is greater or equal to 100,000. So for drug-induced liver injury, hold if the MELD increases by 5 from baseline or the child score increases by 3 points from baseline, plus a greater than 3-fold increase in the ALT from baseline on 2 consecutive occasions. If there is a competing etiology and DILI can be excluded, study drug can be resumed within 3 to 4 days. And if DILI cannot be excluded, the study drug will be permanently discontinued. Additional reasons for study drug discontinuation would be an unexplained elevation in ALT greater than 5 times baseline or greater than 500 units a liter, or an unexplained elevation in AlcPhos greater than 3 times baseline or greater than 500 units a liter. So lab abnormalities. If the platelet count drops to less than 50,000 while they are on the injectable study drugs, the injectable study drugs will be held and resumed when the platelet count is greater than 50,000. For worsening renal function, the site's dispensing pharmacy will check the GFR before dispensing the study drugs for the day. They'll enter it into REDCap, and it will provide guidance on dispensation. The pharmacy will also have a manual for this guidance. For the weekend coverage, the GFR and platelet values from Friday labs may be used to generate. So if the subject's GFR drops to less than 30 but greater than 20 milliliters a minute, and the subject is in the anakinra group, REDCap will provide instructions for pharmacy to dose reduce every other day with placebo 1 day and drug the other. If the GFR drops to less than 20, instructions from REDCap will hold all active anakinra and substitute with placebo only.
Jennifer?
Yep.
This is Lisa from UMass. I was just curious. So, hi. So, can you go back that previous slide?
Sure.
So when it says like when the platelet count resumes to being greater than 50,000 or at any of the checkpoints when some value resumes to being at the level that the drugs can be given. Are those levels just being tested for the next visit, or is there like a protocol for how many times we test those levels before they're returned to the acceptable level?
No, so this is when they're inpatient. When they're outpatient, if they happen to be outpatient, you know, it would be the lab values for that day. So if they come in on day 3, for some reason, miracles, they're outpatient on day 3. As I understand it, when they come in, you know, you'll get their lab values. Now, it'll depend. You'll need to talk with your investigator for day 3. They really have it set up for day 7, but obviously if their lab values have dropped below safety labs, there's going to have to be some communication with whether or not how they're going forward. They really have it set up for day 7. So if they came in on day 7 and their GFR was below that level, or their platelets, especially their GFR, there may be some hospitalization from that. But if for some reason they're going back home, as I understand it, the plan right now is, you know, you're just going to draw again on day 14. However, according to the care team or the primary investigator, you may be bringing them, if they're going back home, I imagine you're bringing them back in for unscheduled safety.
Okay.
So there's no set, you know, other than the regular but scheduled visits. However, with these situations, since we'll closely be monitoring, I'm, you know, with the availability to bring them in for unscheduled safety visits, that's going to be up to the primary investigator to decide. But no set number. That's a good question.
Well, thank you.
Okay, is it clear as mud now? Sorry.
Just like
I know
mud.
there's a lot of, yeah. There's a lot of moving pieces, parts, and, you know, we're always here and to help. So never hesitate to reach out. Of course. So again, laboratory abnormalities. If they're dose reduced to every other day, if the GFR drops to less than 30 but greater than 20, completely stopped if they're less than, GFR is less than 20, and then the optional day 7 if they're outpatient to accommodate for this. So mandatory trial discontinuation. So if they have persistent infection, if they become pregnant, it is not considered an SAE, but of course, they must stop all study medication and be withdrawn from the trial, and then followed by the investigator through the end of the pregnancy, and then mother and infant as considered appropriate. If they have clinical deterioration, so if their MADRS increases by 5 and exceeds 32, or the MELD score increases by 5 and also exceeds 20, the study medication should be stopped. However, they can remain in the trial completing all procedures as detailed in the schedule of procedures. The study drug will be stopped if they have severe leukocytosis of greater than 100,000, and the treating physician may offer any other treatment that is considered as medically indicated and appropriate. And of course, if they have a suspected DILI, my allergy medication is really messing me up here. Sorry, making my mouth.
Can I interrupt?
So,
I have a question.
Of course, please.
Sorry, this is Amy. Can you say that again about the MELD? You said if it increases, I don't have it up on my computer, I'm sorry, but you said.
Oh, no, you're fine.
If it increases by 5 and exceeds
20.
What? I thought it had to be, I thought the MELD had to be between 20 and 35 on randomization day.
I know, it does. Is that, I don't know if that's a typo and we just didn't catch it. Good catch.
Okay.
We'll double. No, that's great. I'm going to have you listen to everything because that didn't, I'll take a look at that again. I have a feeling somewhere it is a typo. So,
Okay.
all
right. Thank you.
Thanks for pointing that out.
Yep.
I'm just reading along. So,
no, that's okay.
Okay. So, AE, SAEs, briefly, because we have gone, I know you're all very competent coordinators, but we're assessing the safety in the terms of AEs and SAEs. And if they're, all of them, whether observed, reported by the patient, labs, et cetera, from day 0 until the participant completes the trial. Using MEDRA terminology, and then a treatment emergent adverse event is any AE that has newly appeared, increased in frequency, or worsened in severity following initiation of study medication. Definition of an SAE: death, life-threatening, persistent or significant incapacity or substantial disruption of normal life functions, congenital anomaly, birth defect, requires in-participant hospitalization or prolongs hospitalization, or an important medical event that may jeopardize the participant and may require medical or surgical intervention. So the relationship of the AE, SAEs to study meds: the investigator at the site will document his or her opinion of the relationship of the AE using the criteria below in this table. If there's a reasonable possibility that the study medication caused the AE, it's otherwise referred to as a suspected adverse reaction. And if there is a reasonable possibility, there is evidence to suggest a causal relationship between the study medication and the AE. So SAE reporting, we're going to send out, or already have sent out, kind of a concise handout to make it easily available for everyone. But you must report the SAE to the DCCIU, Dr. Gare, and Savannah within 2 working days after the investigator identifies the SAE. They should be entered into the REDCap system within 2 working days of the investigator becoming aware. An initial report by telephone that should then be followed as soon as possible by completion of the SAE case report form in REDCap. Any supporting source documentation should be emailed to the assigned contact. Information as soon as possible. At a minimum, the following information should be provided at the time of the initial report: the study ID, a description of the event, at least 1 criterion classifying it as serious, and the name and title of the reporting individual. Additionally, judgment of causality by the investigator must be provided as soon as possible to ensure the timely reporting to regulatory authorities. The site investigator will assess whether the event is causally related to the study medication. The study designated physician, which is Dr. Gare, will consider the investigator's assessment. However, since Dr. Gare holds the IND and is primarily responsible for the overall safety of the participants, his causality assessment will take precedence over that of the site investigator. The study designated physician will determine if an SAE meets the criteria for an IND safety report, which is a SUSAR in accordance with the FDA regulations. We will monitor closely, including all SAEs, AKI, and infection. We will provide unblinded data on SAEs, including infections, acute kidney injury, to the data monitoring board, safety monitoring board, on a monthly basis. And the first DSMB board will be held 3 months after the start of enrollment. We will also have risk-based monitoring, which we hope will help us accumulate this data quickly. And I know our lovely monitor is on the call, Rachel. So just a table of when to report I'm sorry? When to report SAEs. Site requirements for reporting the adverse events. The site AlcHepNet investigators will adjudicate each SAE and SUSAR. The site will email the reports to the parties involved according to the reporting guidelines in the flowchart. Each AE, SAE will include the study ID, the subject-specific number of the adverse event. So this is in our little handout they will send, but it's just a way of keeping numerical track of each AE or SAE. So if it's number 5 and they experience their third AE at Mayo, it would be 5005-3, and you'll keep each AE, SAE separate in your source document. Emailing the SAE per the guidelines, enter the information in the subject line of the email. So again, Mayo SAE report 5005-3, the initial report, and then follow-up number 1, 2, 3, etc. There is an SAE Excel log form that will go along with this. We will send that out to you again to make sure that you have it. And if you have any questions, again, we are always here. Here's the contact list for the SAE reporting. Guess we'll have to take Jacob's name off of there. We will update this list on the handout that we give you as well. Again, it's kind of a one-page thing that we're sending you. So if you're like me, I like everything readily accessible, so you won't have to dig through stuff. All this information will be right there for you, that you can access it easily. If you have unscheduled safety visits, please reach out to the study physician, which is Dr. Gare. Report a pregnancy, and they must be withdrawn from the trial. And then follow the WERB protocol deviation guidelines. Study monitoring, so site initiation, the risk-based monitoring throughout the study and study closeout. Again, our lovely study monitor is Rachel Alvey. I hope I'm saying your name right, Rachel. I apologize. And here is all of her contact information. Source documents, they are in Box for now. They're going to be migrated to a different folder. Our university is changing systems, so we will send that out when that happens. And there will be checklists as well in Box, so you know which form is needed for each visit. There will be additional resources in Box that are listed below, including any supplemental source documents, such as that SAE handout. I've come up with some handouts for the front of the binders for myself that I will share with you to keep track of all the scores we're supposed to be watching in one place, so I don't have to flip between visits. So if feel free to modify those to your need. Points of contact, Savannah and myself, we're always here. Biospecimens, Peter, who is very cheery and amazing today, as he said, which is good. Our red cap, there's that primary email for data, and again, Jacob will have to tell us who we should put here. And regulatory, Savannah is here for all questions. And that's it.